So we'll go ahead and get started. Thanks for everybody for joining us. And let's see if I could advance the slides. I can. Financial disclosures, I have none. So that always makes that part of the talk pretty easy. And if you saw these ahead of time, here are the objectives that we're going to cover today. Clearly talk about the connections between strangulation and sexual violence. We're going to define strangulation using Pennsylvania law, talk about some modes of strangulation and the signs and symptoms of strangulation and some policy and protocol recommendations. And I'm going to try to make some of those broad, but also specific to some of the disciplines that we have on the call, including medical, advocacy, law enforcement, and prosecution, criminal justice, if there's any prosecutors on the phone. So I think we probably are all aware that strangulation represents a pretty serious form of assault, and it could have serious immediate and long-term health and mental health consequences, including death. And where we see most of our strangulation cases and where it's gotten a lot more publicity is around our domestic violence cases, domestic violence relationships. However, strangulation is increasingly seen in sexual violence cases, and we're going to talk a little bit about why now strangulation is so important. And I'm going to offer that for three reasons. Strangulation is a pretty important concept and crime that we really need to take seriously across all of our specialties. The first one is lethality. It's been shown that strangulation is the best predictor of future homicide in domestic violence relationships. And as we know, sexual assault frequently accompanies domestic violence relationships. So the combination of sexual violence, domestic violence, and strangulation in a relationship can really be lethal to that woman. And just as a little bit of an aside, gunshot wounds is the common method of homicide in DV cases, although strangulation itself can cause death and might be as high as number 2 or number 3 following the gunshot wound. Now, when we talk about DV victims and strangulation, Glass and her colleagues found that victims of a prior non-fatal strangulation are 7.5 times more likely to become a homicide victim than those women who were in domestic violence relationships and are not strangled. So that's huge. If you convert that to a percentage, that's almost 800 times or 800% more likely to be a homicide victim. So that's staggering. So for those victims who are experiencing both sexual violence and domestic violence, this is a huge, huge problem. The other reason why it's important is with law enforcement. And for any of the law enforcement officers or folks on the call or the webinar who have family members who are law enforcement officers, this may be a little bit surprising to you. However, our studies have shown that men who strangle women also kill cops. And this is an article out of the Domestic Violence Report from 2014 that showed 2 studies looking at this, and I can tell you that there are a larger study going on in a couple parts of the country looking at this relationship. And this was just looking at it from open access, right to know kind of information, not even a really big in-depth dive into legal proceedings, etc. But there were 2 studies, one in Indiana, one in California. The one in Indiana showed that of 10 officer-involved shootings, 80% of the shooters had a domestic violence history, and of those 30% had a history of non-fatal strangulation against their female partner. And in Riverside, California, they looked at 8 officers over the years killed by an intentional homicide while on duty. 100% of those murderers had a domestic violence history, and 50% of those had a non-fatal strangulation history. So this is very important for law enforcement officers when responding to domestic violence scenes, and I would extend that even to sexual violence scenes where they need to protect themselves. They should go with more than one officer if possible, and always be on the alert and be prepared for something to potentially happen. And then the third reason why it's important, and at least important in Pennsylvania, is we now have a strangulation law. We have a strangulation felony law here in Pennsylvania. Act 111 was signed in October 2016 by Governor Wolf, and here's a picture of him at that signing. And what it does is it codifies strangulation under the assault crimes and offenses statute. Here is the definition of it. So for the state, it's knowingly or unintentionally impeding breathing or circulation of the blood of another person by applying pressure to the throat or neck or blocking the nose and mouth of the person. They talk about physical injury, that you do not have to inflict a physical injury. There doesn't have to be physical evidence of an injury to the victim. And we'll talk about why that's important later on, and that it's not an affirmative defense. Here's a summary of where these crimes fall. So it's a first-degree felony if there's an active protection from abuse order against the assailant. There's an active sexual violence or intimidation protection order against the assailant. If it's used as an instrument of crime. So if a woman is sexually assaulted while walking down the street by a stranger and part of that crime involves strangulation, he used the strangulation as an instrument of the crime, therefore it could be charged as a first-degree felony. Or if there was a previous conviction for strangulation in Pennsylvania or any other jurisdiction in the United States, it's a first-degree felony. It's a second-degree felony if it's against a family or household member, by a caretaker against a care-dependent person, so a health worker, health aide who strangles a patient, or if it's done in conjunction with sexual violence, stalking, or human trafficking. And then all other cases of non-fatal strangulation are second-degree misdemeanor charges. So I think this is for law enforcement and for prosecutors, this is a nice little table taken right from the long, lengthy statute to summarize where the charge would fall based on the relationship between the assailant and the victim. And this is just a web posting from the Pittsburgh Post-Gazette from April of last year that more than 100 people in that area had now been charged under the new law. So what we've seen across the country is as states enact felony-level strangulation statutes and laws, the amount of charges increase. The amount of charges filed against perpetrators in those states have increased, and they're getting longer sentences and jail time. Now, let's go on and talk about what you're here to talk about today, the connection with sexual violence. And I commend Babs for doing this webinar because this is one connection that people don't often think of, but we know we're seeing it. Okay? As we all know, sexual violence is about power and control, and strangulation is a very effective way to exert that power and control over someone. Just think about it. You're being strangled by somebody, whether they're somebody you know, somebody you love, or a total stranger. You have a fear of death. You're struggling to breathe. You're going to become very compliant. You're going to lack. You're not going to resist. You're going to do what that person tells you because you're so afraid of dying. The other possibility that can happen is that in the act of strangling somebody, you could render them unconscious. So you may be trying to fight. You may be trying to escape or break free, but then you become unconscious, and therefore the sexual violence can proceed. We had a case here in Philadelphia about 3 years ago now, on a holiday where somebody was raped in this way, where the assailant, ambushed her, strangled her twice, got her unconscious, dragged her to a different location within the parking structure, and sexually assaulted her. When she woke up, strangled her again, and then continued with the assault. And if you look at the literature, strangulation is actually a common cause of death in sexual assault homicides. Whether the death was intentional or not doesn't matter. It still could result in a death. So when we talk about the true incidence of strangulation and sexual violence, we really don't have great statistics about it. The literature reports ranges of anywhere from 5 to 25%. Excuse me. I can tell you Here in Philadelphia, in looking at our records of 2,000 to 3,000 cases over the years, we probably have about a 15% rate of strangulation associated with our sexual assault patients who present to our center. I have colleagues who work in part of Colorado, and when talking to them, they say that it's actually about 50% of their sexual violence cases actually are associated with strangulation. And in certain populations, it may even be higher than what the literature tells us. It's clearly higher in domestic violence relationships, could be potentially higher in Native American populations and cultures as well. Looking at the literature, this article or study from 2016 in the Journal of Forensic and Legal Medicine in Australia looked at age 13 and over women referred to a sexual assault center over almost a 5 to 6 year period. They had 1,755 women who came in for treatment, and about 1,064 were included in the study. 7.4% of them reported a non-fatal strangulation. And it's interesting here to note that the intimate partner perpetrator was more common in the non-fatal strangulation cases. So this is another example of domestic violence with sexual violence. The odds ratio of non-fatal strangulation was 8.4 times higher for women assaulted by an intimate partner and 4.9 times higher for women assaulted by a stranger. So clearly a greater risk for being assaulted by your partner. However, it's still, in the stranger cases, there was 5 times more likely. Of the non-fatal strangulation patients, 24.1% had no signs or symptoms of strangulation. And that's important, and we're going to talk even more about that later on. But 24% had no signs or symptoms of strangulation. About 50% had maybe one sign, and 67% had one symptom. I've included on the slide what those findings were. So linear neck abrasions were about 32%, and about 21-22% were some petechial bruising of the upper neck and face. Of the symptoms, the common ones were neck and throat pain, tenderness to palpation of the neck, and then painful swallowing. Interesting, look at the bottom there, loss of consciousness is only at about 9%, and we're going to talk about the importance of unconsciousness later on when we talk about the signs and symptoms of strangulation. So now let's talk about what happens during asphyxia. Asphyxia is the common pathway that we see in our strangulation cases. So let's start with that definition again of strangulation. It's a form of asphyxia characterized by closure of the blood vessels and or air passages of the neck as a result of external pressure on the neck. So basically, you squeeze the neck, you block either the blood flow or the air flow, and you cause a low oxygen state in the body. Now, we know that there are 2 kinds of strangulation. The first kind is manual strangulation, using a hand or hands, using an arm, using a leg, or a technique called the carotid restraint, or it's actually also called the rear naked chokehold or just a chokehold, where the arm, upper arm, forearm are used across the neck with the perpetrator from behind. And the goal there is to squeeze the carotid arteries to block blood flow to the brain to render somebody unconscious. When dealing with manual strangulation, it's often helpful to know which hand was involved. Was it the right, the left, or both? And did it occur from the front or the back? And this is important because based on what you see on your physical exam, you could correlate position of the assailant with the victim and expect to find injuries in those respective locations. The other kind of strangulation is a ligature strangulation. This is where some object, usually a piece of clothing, maybe a tie, maybe a scarf, or a household object like a telephone cord or a wire or a cable from a computer or charger, is used to be wrapped around the neck and exert that force or pressure across the neck. Here it's important to know what the object was if the victim can tell you, because you may be able to look for a pattern of injury. You may be able to see that pattern that got transferred from the object onto the victim neck or skin. Okay? Now, suffocation, if you remember back to the Pennsylvania statute, it includes for suffocation, where it's a form of asphyxia characterized by blockage of the nose and mouth by an object or body parts. So whether it's a pillow or a plastic bag or your hand and arm, you're blocking the nose, blocking the mouth, therefore not allowing oxygen to get into the system, into the body, and therefore causing that low oxygen state. This is included because a lot of the consequences of suffocation are the same as the consequences and physical findings of strangulation. So that's why they're both included in the Pennsylvania statute. We actually see that a lot of the domestic violence cases, they have strangulation, usually manual strangulation, but the actual act of strangulation with pressure on the neck. In a lot of the sexual violence cases, what we actually see is suffocation. Now, it could have a combination of both as well. But suffocation, we oftentimes see, especially, you try to keep somebody quiet or make less noise, and you put your hand over their mouth and their nose. If you block those air passages enough, you'll cause a low oxygen state in the person. And then the last one is positional asphyxia. And we don't think of this as much, or we don't even ask that much about it, but this is due to force on the thoracic or chest cavity, thus impeding or impeding oxygen inflow. So imagine somebody, and it doesn't necessarily have to be somebody much larger than the person, but if that perpetrator is larger, the effect is much greater. But that person sitting on somebody's chest or leaning on their chest, impeding the ability of the chest muscles to rise and fall properly during inhalation, thus not filling the lungs with the right amount of oxygen to allow for proper gas exchange. That too can lead to a state of low oxygen in the body. And you may also hear this one referred to as burking, B-U-R-K-I-N-G. This is after the person who made this crime famous, and due to the interest of time, I'll leave you, your homework assignment is to Google that, and you'll have some very entertaining stories to read. Now, let's talk about what happens when somebody's strangled, and what happens in the body, what happens within the blood vessels and in the trachea and in the brain, and this will provide a good foundation for what are the signs and symptoms of strangulation that we're going to see with our patients. So I told you that, the pathway or the final common pathway for this is asphyxia, that low oxygen state, and that it can occur be three ways. The first one is jugular vein obstruction. The next one is carotid artery obstruction. And the last one is tracheal obstruction. Okay? So let's talk about each one a little bit before we move on. So jugular vein, the jugular veins carry the deoxygenated blood from the brain back down to the heart and lungs. Okay? Blocking this will not allow the blood to return from the brain. Therefore, that blood will pool up in the brain, stay up in the brain, and bathe it with a low oxygen, acidotic, toxin-filled environment, which the brain doesn't like. So just by blocking the jugular veins, you could develop unconsciousness, you could burst blood vessels from that buildup of pressure in the brain, the small capillaries in the face that we talk about when we talk about petechiae. The carotid arteries, on the other hand, bring the good oxygenated blood from the heart up into the brain. The carotid arteries, when they're occluded, a few things can happen. One is that if they're totally blocked, either on both sides or one side, you could cause serious impairment of blood flow to the brain, leading to things like unconsciousness, especially if both sides are blocked, or a stroke. If only one side's blocked and it's blocked long enough, you don't get blood flow to that part of your brain, you're going to have a stroke. But what can also happen is that you could injure the carotid artery. So inside of the artery, you could cause a little tear, a little disruption in the inside of the artery, or that compression itself might be able to start the clotting process and you form a little clot in that carotid artery. Either way, that injury or clot formation can also lead to a stroke because that clot could dislodge, or in the case of an injury to the blood vessel, a little tear on the inside of the blood vessel can lead to what we call a carotid artery dissection, where the blood flows between the layers of the vessel and not effectively go to the brain, therefore causing less blood flow to part of the brain and leading to a stroke. And finally, tracheal obstruction. The trachea is your windpipe. By blocking that, you once again block airflow into the lungs, causing a low oxygen state in the lungs. It can't effectively exchange gases and supply oxygen to the body. So once again, with the tracheal obstruction, you'll often see unconsciousness due to that low oxygen state. So once again, those three mechanisms: jugular vein obstruction, carotid artery obstruction, trachea obstruction. You either block the blood flow to the brain or the oxygen flow into the body, all leading to serious consequences that can be seen in any of our strangulation victims. And we're going to talk about those again in a little while. One of the things that people often ask is, well, how much force does it take? How much pressure does it take? And now these are just estimates. Everybody's different, depending on how well developed you are, how well developed the neck muscles are, your age, excuse me, your health status, any medications that you might be on. But to block the jugular vein only takes about 4.4 pounds of pressure on average. To obstruct or block the carotid artery, that takes about 11 pounds of pressure. And then to block the trachea, the air passages, it takes about 33 pounds of pressure. And that makes sense that structure is a little bit stronger. Otherwise, every time we bent our neck, it would flop over on itself and we would be in a low oxygen state and unable to breathe. Now, I know those numbers don't mean a lot to folks on the call because you don't have any reference points, but let's look across the way and some of the things we all know about or have done in our careers or for recreational purposes, etc. So in order to pull the trigger on most handguns, it's about 5 pounds of pressure. And actually, that's a range of about 4.5 to 6 pounds. So the same amount of pressure to pull the trigger on a handgun can be used to block somebody's jugular vein. To open a soda can, those pop open cans, it takes about 20 pounds of pressure to be exerted on that tab to open it. And then a good handshake can generate 80 to 120 pounds of pressure. And in some cases, that can actually go up to even 180 pounds of pressure from just a single handshake. So there are things we do in our daily lives that require or take far more pressure than it does to kill somebody. So, strangling somebody with those lower number on the screen can really lead to serious bodily impairment, injury, and even death. So now when we talk about somebody who's strangled, let's look at what our pathway is of what happens. So somebody's strangled. From numerous studies, and there's literature out there from both hanging studies as well as strangulation studies that show if that strangulation continues for about 5 to 30 seconds, you could lead to unconsciousness. You could develop a loss of consciousness. And then anywhere from 4 to 6 minutes of that loss of consciousness, that lack of oxygen, you could become brain dead. Now, the problem, I made this look so nice and linear and across the board. The problem with this is that this is not necessarily how a person would react, because oftentimes there's periods of letting go and holding on tighter, so that 5 to 30 seconds may be a little bit longer. You're trying to struggle, so as you pull their hand away a little bit, you may be able to get some air in, get some blood flow going, but then if it comes back, it starts all over again. The other flaw to this pathway is that what we're taught as 4 to 6 minutes leading to brain death may actually be a lot shorter. That 4 to 6 minutes is in animal studies. Unfortunately, we have no way to study it in humans. Unfortunately, people don't volunteer for this kind of study, and the IRBs wouldn't approve it. But we really don't know how long it takes for somebody to become brain dead. We know how long it takes animals in animal studies or other trauma studies and circulatory studies to become brain dead. And we extrapolate that number to what it'll take for a human. But it may actually be only 2 minutes or 3 minutes. So it's our best guess that it's 4 to 6 minutes. But realize that 4 to 6 minutes still isn't that long. There's a lot of things we do in our daily lives that take more than 4 to 6 minutes to complete. And in that brief period of time, you could render somebody brain dead. After we have this discussion, I'd like to show this slide of factors that actually affect injury and death in strangulation. And I like to divide them as, some strangulation factors, and then other ones are victim or patient, whatever terminology you'd like to use, factors. So with regarding to the strangulation itself, there's a lot of physics involved in strangulation in that how big of a surface area, how much force, how long is the force, how is that force directed, over what exact location is it directed? Is the hand directly over the carotid artery where the artery is getting the maximum amount of pressure and impact, or is it over a much wider area, or is the hand a little bit misplaced and therefore it's not getting those blood vessels as easily as it would if the hand was in a different location? So all of those strangulation factors are involved in whether somebody can live or die, or how much injury they may or may not sustain. With regards to the person themselves, things like age, health status, any medications, so medications that might, predispose to more bruising or hemorrhaging within the tissues can be more detrimental. How well their neck muscles are. Are they, elderly and may have some weak neck muscles, making it very easy to get at those blood vessels and trachea? Or is it somebody who's well-developed, athlete, who may have a really large muscular neck and make it much difficult to constrict them? Intoxication can also play a role, both alcohol and drugs or medication intoxication, because they may alter how susceptible the person is to that lack of oxygen. So if somebody's already under the influence of a drug or toxin, just a little bit of deprivation of oxygen might be enough to cause a more serious injury than somebody who wasn't intoxicated. And then the whole theory around continuous or intermittent oxygen deprivation. Is that hand on the neck there continuously for X amount of time, or is it a let go, release, or ease up on the neck for a little bit, see what happens, and then you go back to strangulation? In the case that we had here in our parking garage that I described earlier, there was a continuous strangulation up to the point of unconsciousness, and then during that period of unconsciousness, he was able to move the victim to a different location, undress her, and begin the sexual assault. It was when she woke up and started to come to that he went back onto the neck with his hands, strangled her even longer, and rendered her unconscious again. Also, the ability to defend oneself. So if you're fighting back, if you're trying to squirm, if you're trying to get their hand away from your neck and you're pulling your neck away and trying to pull their arm away, that will release the pressure a little bit and change that force on the neck. So that force may not be as continuous as, you think it is. And then the ability to seek medical attention. Are you able to wake up from what happened? Do you have the knowledge, or are you aware enough to call 911, get help, seek medical attention, and hopefully if there's something going on, it could be reversed and treated. So it's not just a grab the neck, squeeze, and somebody can die or somebody can have serious injuries. There's a lot of factors that go into whether somebody is seriously injured or killed from strangulation. And there's still a lot we actually don't know about the topic. But these are some of the best guesses as to what happens related to those factors and injury. Speaking of injury, Once again, I want to remind folks that only about half of strangled patients will have any visible signs of injury. When I say visible signs of injury, these are things that you could see with your naked eye. Just by looking at somebody, just by talking to them, you could look at them and see these findings and associate it with the strangulation. And we know from autopsy studies and other forensic medicine studies that it is possible to strangle someone to death and leave no marks or no signs on the body. All of the damage is inside and can only be seen at autopsy. Dean Hawley, a forensic pathologist who I reference here, is a friend of mine and a colleague. We teach together at the Strangulation Training Institute. His famous quote is that the best examination for strangulation is an autopsy, because we can only see what we could see with our eyes on the outside of the body. He is able to look inside the body, where oftentimes he finds many more areas of injury and bruising and hemorrhage than present on the outside of the entire body. So that's why it's possible to not have any signs, any marks on the body, yet still have a significant strangulation, even a strangulation homicide. Let's talk now a little bit about the signs and symptoms of strangulation. So I have some references where these have been pulled from. There's others out there that you could access as well. And just to get everybody on the same playing field, the signs of strangulation are the things that we as officers or examiners or advocacy folks and crisis counselors, these are the things we see. We could see them with our eyes. The person can show us a bruise, an injury, etc. Symptoms are what the person tells us they're experiencing. So they're having pain here or a sore throat, those kind of things. So that's what we talk about when we talk about the signs and symptoms. This is a schematic cartoon drawing chart available on the Training Institute's website. It's available for free. You could download it there. I'll show you how at the end of the webinar. And it's a great pictorial of the signs and symptoms of strangulation. And if you go around, clockwise starting at the top, you get to see all of the body parts that are often affected, including the skin and of the scalp and the head and neck, the ears, the mouth, the neck itself, the respiratory system with breathing changes, voice and throat changes, chest complaints, facial changes and complaints, injuries to the eyes and eyelids and findings there, and then a whole plethora of neurological symptoms. Today's webinar is a little time constricted, so I don't have time to go into a lot of detail related to all of these signs and symptoms. So I'm going to break it down a little bit for folks just to pay attention to things. But remember, only 50% of patients will have any visible injury. So 50% have no visible injury. And of those who actually have injuries, 35% of them were actually too minor to even photograph. So maybe you saw something when you looked, but when you took a photo of it, it didn't appear that well in the photo. And then of all strangulation victims in the study by Gail Strack, only 3% of them sought any medical attention. So there were 300 patients in the study, 3 of them sought medical attention. So that's another goal of our institute, is to get people to realize how serious strangulation is, and that the victims of it need medical attention to look for injuries, underlying injuries, and to help document what happened to them and what's going on. So when we talk about some of the signs and symptoms, I like to divide them into different body parts. So when we talk about the head, some of the things we can see are petechiae, or those tiny red dots from ruptured blood vessels. You could see subconjunctival hemorrhage or bleeding into the white part of the eye. You could see bruises on the jaw, the mastoid areas behind the ear, and I'm going to have some pictures of these later on. With regard to the neck, you might see redness and bruising. You might see abrasions and scrapes. It'll be tender, painful to touch. There may be swelling. You may be able to determine that there's a laryngeal fracture or fracture to the airway, either by your examination or through radiographic analysis. And then you may actually see a ligature mark. You may see a circular pattern around the neck. With regards to the voice could be slurred. You could actually lose voice or have a very hoarse or raspy voice. It used to be thought that the voice changes were actually due to direct injury to the vocal cords. What we know now is, yes, the injury to the vocal cords directly can happen, and you can injure the voice box, etc. But the most common reason why people have hoarse voice or voice changes after strangulation is due to injury of the nerve that innervates the vocal cords. So your vocal cords could look perfect, and you have no bruising or no injury to them specifically, but it's an injury to the nerve that goes to them that makes them not work proper, and therefore have you with a raspy or low sounding voice. Visual changes are common. Patients often tell us they see stars or dots or flashing lights. And hearing is actually different. They say sound very muffled, or they sound very loud and roaring at them. And then, regarding our throat and swallowing, we often will have painful swallowing, difficulty swallowing. We actually may drool because it hurts so bad to swallow that the saliva builds up and we can't swallow it because it hurts so bad. Oftentimes we see respiratory complaints in patients, and these include noisy breathing, fluid on the lungs or rales, just generalized shortness of breath. They could cough up blood, they could develop pulmonary edema, or they could aspirate and develop a pneumonia. And that's where stomach contents come up into your back of your throat, and instead of going back down in the esophagus and into the stomach, they pop over and go into the trachea, and then they go down into the lungs, and they can get into the lung tissue, damage the lung tissue, and set up for an infection. In one of the studies, shortness of breath was actually the most common symptom reported by victims, and I think that's probably multifactorial. One is, it's a high-stress environment. A lot of things are going on. You're trying to struggle for your life, and I think you just have that adrenaline and that shortness of breath feeling. But also, think about it from the body's perspective. Oxygen is being deprived to the body, and the body's best way to increase the oxygen is to breathe more air in and increase that oxygen concentration in the blood. So if you have a low oxygen state because you're being strangled, your body's reflex is going to be breathe faster, bring more air in, bring more oxygen in, and we could get that level higher. And the last reason why a lot of victims complain of shortness of breath is that they actually might have something wrong. They might have a pneumonia or an aspiration or something called pulmonary edema, CHF kind of fluid in the lungs. So those are some of the highlights related to those organ systems and what symptoms you may see when you're dealing with a patient. The neurological symptoms are vast and can be as simple as just some lightheadedness to dizziness, all the way to headache, to confusion. You may have numbness and tingling, memory loss. You may have stroke symptoms or weakness in different parts of your body. And then the two highlighted processes in red are important, and I'm going to take a few seconds to just talk about those individually. And those two are incontinence and unconsciousness. So unconsciousness is actually a serious complication of strangulation. It indicates that there was a problem with cerebral blood flow. So what it means is that for some period of time, the blood flow to the brain was compromised, and the person's brain in that region did not function properly, and it caused them to have either just unconsciousness from that lack of blood flow, or that it led to an injury like a stroke or like a possible TIA, and they couldn't get their cerebral perfusion restored by removing whatever the process was, and that's why they became unconscious. Oftentimes when we talk to patients, they don't know that they went unconscious. They can't remember it. They weren't awake for it, and they don't know what happened. So we oftentimes have to infer that something happened due to history and talking to the patient. So things that we ask about are there any unexplained injuries? I don't know how I got this injury. I don't know how this happened, or my hand hurts. Was there any change in location? So in our case here in Philadelphia that I talked about, the victim clearly remembered being at the elevator when the guy approached her, grabbed her, and put his hands on his neck. When she woke up, she was behind a car that wasn't her car. It was in a totally different part of the parking lot. So you had that change in location. In some of the domestic violence relationships, we hear that we were arguing in the kitchen, and then I woke up in the bedroom, or I was on the bed, and I don't know how to get there. Or just even a change in position. I might have been, in the kitchen, I was standing there talking, and then I woke up, I was on the floor, or I was maybe in a different position, or that. And the other thing are time lapses. So the victim may report that they don't remember part of the day, or things like, well, when we started the argument, or he started choking me, strangling me, this show was on TV, and then the next thing I know, there was this other show on TV. And I don't remember anything about the shows in between and that. So it's important to really ask about unconsciousness in our strangulation victims, and to try to ask some of these surrounding questions around unexplained injuries or changes in locations, positions, and time lapses to accurately assess if unconsciousness happened. The other neurological symptom is incontinence, and this could be urinary or fecal incontinence. And what this indicates is that there was an alteration in cerebral blood flow and consciousness, because what happens is when you alter that cerebral blood flow and those nerve receptors don't work well, they lose control of the sphincters. Now, sphincters are the muscles that keep us from peeing on ourselves, vomiting on ourselves, and pooping on ourselves. So when those are all under control of the brain and the nervous system, when that control is lost, those sphincters will open up, and we develop incontinence. Once again, this is something that a patient may not tell you about right out. They're often embarrassed or ashamed to report it. Think about it. Would you like a stranger, a police officer, or a nurse, or somebody in the hospital, or a paramedic EMT responding to you? You don't know them. You're under a lot of stress. You had this horrific thing happen to you, and you're going to freely disclose to them that you urinated on yourself or defecated on yourself? No. Most women will change clothes or hide it at the house if it happened on a bed, or if the bed was wet, they'll cover it up, put the sheets and the blanket back over it. So you may have to normalize it for the patient. You may have to bring it up yourself and see how they answer the question. One of the ways I like to do it, and there's a couple of ways, not that this is the right way, but I like to say oftentimes women I care for who were strangled tell me that they wet themselves. By any chance did this happen to you? Because they don't know why it happened to them. They just know that they woke up, they were wet, what happened, and they don't want to have any judgments placed on them, so they'll not even report it. And then, if that doesn't work, with that kind of line of questioning, you may want to ask them, are those the clothes you were wearing when the assault happened? And if they answer no, you could ask them, what happened to them, or where are they? Why did you change them? And you may get the answer of, well, they were wet when I came to, and I didn't know what happened, so I changed my clothes. I was embarrassed. And then, like I mentioned earlier, too, there are several long-term consequences of strangulation, including stroke due to injury to that carotid artery, the carotid dissection that I mentioned. The literature is full of cases where somebody had a carotid dissection days, hours, weeks, months, even years before the stroke ever happened. And in all of these cases, or most of these cases, they did not even know that they had the carotid dissection. And this is just not even from strangulation, but in any other causes of carotid dissection, the stroke can appear at any time. We have long-term consequences related to anxiety, post-traumatic stress disorder, chronic headaches, depression, suicidality, and memory loss, because for those of you who are familiar with any of the neurobiology of trauma literature and studies, that the memory forming part of the brain, the hippocampus and the amygdala, those are some of the most sensitive parts of the brain to that lack of oxygen. So therefore, if you don't have oxygen going to that part of the brain, you can't form memories properly, and your memories are disjointed and very fragmented. And it may take quite a while to come back or get that memory back, and in some cases it may never come back. Let's move on now and talk about some of the visible injuries that we see with strangulation. I have some photographs here. I have permission to use all of these and to share them. Some of them are from the training center. Some of them are from my own patients and files. So I assure you that I have permission to use them and share them. And when I could, I blocked out any visible identifying features, but I will tell you that some of these photos are used nationally and have been on websites and textbooks without any covering or de-identification, so I use them in their same form here. So this is a woman who was strangled by her partner, and you could see the mark, those visible bruises on the neck. Right there on the right side of her neck, she has some abrasions, she has some scratches, she has redness, all on the side of her neck. This is an older photo, but this highlights very nicely, I don't know if you guys can see it here, these crescent-shaped impressions or bruises on the right side of her neck. Those are fingernails. So we know that the hand was placed on, that side of the neck, and those fingernails dug from the pressure right into the neck, leaving those impressions or those marks. Another photo showing a bruise under the chin. This is caused by our natural instinct when somebody's going for our neck to drop our neck. So we put our chin to our chest, trying to block that area so they can't get their hand in there. And what can happen is the hand can get under there, and as you're trying to fight and push it away or get your chin down even closer to your chest, you could cause bruising underneath your chin and find this telltale sign. Now notice the way she's looking. She's not looking straight at the camera. She's actually looking up at the ceiling with her head tipped back. You could miss these if you don't put the person in this position or specifically look under her chin to see this bruise, this injury. Okay? So this is a chin abrasion bruise due to chin lowering position. You could also see scrapes. So here's a dramatic photo of 4 linear parallel scrape marks on the side of this woman's neck. I think you could all guess what caused those. If not, put your hand out straight in front of you and you'll see those 4 objects of the crime right there in front of you, your 4 fingers, and those were the finger marks as they were dragged across her neck and held across her neck as she tried to get away. The case that I showed you the first photo of, I saved the close-up shot of it or the more blown-up shot of it, and here are those finger marks. 1, 2, 3, and probably the 4th, linear, parallel, abrasions, red marks on the neck due to finger marks, due to fingers being on this person's neck. Dramatic photo again. These are what we call claw marks. So in this case, hands on the neck, maybe a ligature as well, and then trying to fight to get it off, she is scratching at herself, pulling that object or pulling those hands away. But as she's doing it, if she has longer fingernails, she's able to injure herself. She's able to scratch herself, trying to get that obstruction relieved so she could breathe or have blood flow come back into her system. Here's another picture of injury to behind the ear. This we see due to injury or tearing of the sternocleidomastoid muscle. So that muscle is the large muscle that runs from behind your ear down to your sternum and clavicle. It's a large muscle that helps with your neck movement and being able to turn your head from side to side. That can be injured, and those fibers can be torn and bruised, and you could see this redness right behind the ear here like you do here. Sometimes it looks more like bruising, like an ecchymosis, or you could just see redness. There may or may not be some tenderness or pain back there when you press on the area. And then the other thing we can see on the neck are thumb or fingerprint bruises. Here's another patient who was strangled and has these oval to circular bruises on her neck, all corresponding to different fingers that were used during the strangulation on her. And these could be seen either one on a side, depending if it's from the thumb, or you could see multiple in a location if it referred to the other four fingers. And this is where it helps to know what the position of the victim was to the strangler and which hand was used, etc. Next, I want to talk a little bit about petechiae and what they are, because I think they get the biggest rap, or everybody hears about petechiae in strangulation cases. I know on CSI, whatever city you want to be in, or Law and Order, we always hear about petechiae because everybody who's strangled on those shows have petechiae. But petechiae are actually due to rupture of the tiny capillaries and venules due to jugular vein compression. So like we talked about earlier, if you're compressing that jugular vein, the blood isn't coming back down from the brain. It's pooling in the brain, and the pressure in that vein is just increasing and increasing and increasing. And then it gets transmitted to the tiny capillaries and venules adjacent to it, and those are weaker structures. And as the pressure increases inside of them, they rupture. And you get these tiny little red dots on the skin surface that we call petechiae. But guess what? They can also occur internally. You can also see them in the muscle. You can see them within the brain tissue. The problem is none of our imaging modalities, CAT scan, MRI, are all that sensitive to pick up those tiny little microhemorrhages in the tissues or in the brain tissue to actually see the petechiae. So that's why the autopsy is a much better study, because you could actually open up the body and actually see them with your own eyes. They're usually gone in about 1 to 3 days afterwards, so they may not be there depending on when the evaluation takes place. And here's just some examples. Here's somebody with one tiny red spot in the eye after being strangled. Here's a child who was strangled, and here's a whole cluster of petechiae all on that upper eyelid. Here's the neck of that child. You actually see there's an abrasion on the neck. Here's a finger bruise. Maybe it was a chin-lowering bruise, but a clearly round, circular like a finger. There's some redness and bruising over his chin, and then all of these tiny red dots that when you press on them, they don't go away. They stay there, indicating that they're from a ruptured blood vessel. And here's another picture of the neck of somebody who was strangled with just a ton of those tiny little petechiae. And then lastly, some of the other visible findings we may see are ligature marks. So here's a ligature mark around this person's neck, around to the side of the neck. And then here's an interesting case of a very thin wire cord that was used. And if you notice here, you could trace it with this upward pattern. So what actually happened was she was in a position lower than her assailant. I can't remember if she was sitting on the floor or she might have been in a chair and he was standing up, and wrapped the ligature around her neck and actually pulled upward. So you get this upward appearance of the ligature. Now let's talk a little bit about the emergency management of the strangulation victim. I know we don't have a lot of nurses on the call, so I'll make this brief, but I think everybody should just get a flavor of what should happen when somebody's strangled. So when you talk about care of the strangulation rape victim in the emergency department, I like to use this diagram to say that it's really a team effort. It's an effort between the emergency physician, the sexual assault nurse examiner, and the rape crisis center or the rape crisis counselor advocate, okay? Because everybody has a role to play, and in the center there is where we all overlap to take care of the victim. So that should be our main focus, once again, is to care for that victim, but realize that within each of our own spheres, we have some things to accomplish and we need to do for that patient. So I'm going to go right out and tell you now, any victim of strangulation needs to have a medical evaluation. Now, in cases of sexual assault and strangulation, most likely most patients are going to go to the emergency room because they want to get a forensic medical exam following their sexual assault. So it's, it's often easier to get those patients to the hospital than it is to get domestic violence victims to the hospital. But anybody who's strangled really should have a medical evaluation. And like I said, the ideal system includes a medical evaluation by the emergency physician to rule out any serious injuries, to evaluate for carotid dissection, to decide on whether radiographs are necessary, and then to have the forensic evaluation by the sexual assault nurse examiner or the forensic nurse examiner. And this forensic evaluation should include physical evidence and recovery kit collection, photographs and documentation of any injuries. They should perform a very detailed examination of the head and neck, as well as the other parts of the body for any evidence of the strangulation. And then potentially helpful in stranger DNA cases are the use of touch DNA, trying to recover epithelial cell DNA from the skin of the victim. We have a protocol at our center that anybody who is sexually assaulted, especially by a stranger that has strangulation, we ask them for any specific parts of the body that were contacted by the assailant, as well as the neck, and then we swab those areas for touch DNA so that the crime lab may be able to pull a DNA profile from it. Okay? And then when caring for these patients, a protocol is always helpful. So you should have a protocol of who does what, what's expected of everybody, what's going to happen to, from the SANE perspective, from the ED perspective, et cetera. And it's actually best practice to use a designated documentation tool. Here's a copy of one that's available on the website I'm going to show you at the end. You can download it from there. There's others out there as well. Here's the one we use at our center and our computer documentation program. We have it created this way. So there's a bunch of questions that you could ask the victim, and then when you do your physical exam, it highlights any of these areas or body parts where we're bound to see or often see injuries and complaints, and we could check off what was there. Now, what about radiographic evaluation? I mentioned this earlier. The Training Institute on Strangulation Prevention has a medical advisory panel. We met about 2 years ago, reviewed a lot of literature to try to come up with an evidence-based guideline for folks to know who to x-ray and what kind of x-rays we need to get in strangulation victims. I will tell you that it's not really evidence-based because there isn't any out there. At best, ours is evidence-informed. And it's also important to realize that when talking to different disciplines around this need, there's a medical need. So we want to do what's medically needed for the patient, and we'll help find injuries and problems and prevent, stroke and carotid dissections, et cetera, versus what's forensically helpful. Because a lot of the things that we get results on actually have some forensic implication, but may not be medically needed for the patient or helpful to the patient. So that becomes a huge issue when deciding what kind of study we need. So, or what kind of test we need, I should say. And what we really need is a very large national research study to show what is the best way of deciding who needs to be imaged and what imaging study needs to happen. You can't read this, but this is what if you went to the website from the Strangulation Institute, this is what our radiographic guideline looks like in total, but it's a large file, so therefore on the slide it looks very blurry. However, I will highlight the top part of it. This is what it's called, Recommendations for the Medical Radiographic Evaluation of Acute Adult Non-Fatal Strangulation. And then it goes through the whole steps of it. I'm not going to go over it today, but I just wanted to show it to you so you guys see it. You could download it. And I will tell you that in the next few months, we're going to have one for the evaluation of acute pediatric non-fatal strangulation. And we're going to also have recommendations related to the pregnant strangulation patient. So all of those will be forthcoming shortly. As always, we want to be able to have the victim best interest in mind. We want to have them have a safe discharge from the emergency department. So after whatever we do for them in the emergency department, they have to meet certain criteria to be able to go home. They should have normal vital signs. They should have the ability to take oral fluids. They should not be intoxicated. And if we did any radiographic imaging, it should be normal. And if they are going to go home, they really should have a very clear follow-up plan of where to go for any problems, who to follow up with. They really need to look for warning signs of what happens they should come back for. The three big ones I like to tell my patients are if you develop any trouble breathing or shortness of breath, get right back to the emergency room. Because some of those problems that I mentioned in the earlier slides actually take hours and sometimes up to 48 hours to develop. So any breathing difficulties, and especially those first 2 days, need to be looked at again. If they're unable to take oral fluids, they need to come back for IV fluids. And there's several cases of people becoming so dehydrated that they suffered kidney injuries and kidney damage from dehydration because they weren't able to swallow. And then any new neurological complaints, new weakness, new numbness, tingling, visual changes, any kind of neurological symptom they need to return to. We often ask our patients to keep a symptoms log of what's been going on over the next couple of days, and then they should always have clear referral patterns or instructions for advocacy center, the police, any victims services agencies that you work with. All of this should be provided to the patient at the time of their discharge. One of the other big pieces of all of this is the key to discharge planning is safety planning. The patient must verbalize a safe place to go or have a safe place to go, especially in cases of DV or if they know who their assailant is from the sexual assault. We as healthcare providers usually advocate this over to the advocates to perform, but nowadays police are receiving training on how to do this. There's a lot of ways to come up with the safety plan. One of the things around the safety plan is using a lethality screen as well. And there's a few things you could use. One is the danger assessment by Dr. Campbell. The other one is the One Love app, which is a $2 app on the iPhone that you could, ask the person questions and it comes up with their risk for lethality. And then the other one that people might have heard about is the Maryland Danger Assessment. And this one is available for training through PCCD, and I think I'm going to talk about that a little bit later when we get to the advocacy piece. So now let's talk about the law enforcement response. Let's talk about what makes a good law enforcement response when coming to a scene where strangulation has occurred. Unfortunately, oftentimes the law enforcement officer is the only responder because a lot of our victims, and even our sexual assault victims, will decline any medical care. I think one of the jobs of the officer is to strongly encourage that they seek medical care, help them get to that medical care, and if not wanting to go to the hospital, at least call 911 and have a paramedic or EMT come to the scene and evaluate the patient. And hopefully they're trained as well, and we'll encourage them to seek medical attention. The other thing that I can strongly support for our officers is to really do thorough documentation. Very thorough and complete documentation. including some of the signs and symptoms that they see. A lot of times this police report is the only documentation of what happened and what those signs and symptoms are. And I could tell you that I do a lot of expert witness work in Pennsylvania and across the country in these strangulation cases. And even in cases where the patient goes to the hospital, I sometimes have better documentation of what happened and what signs and symptoms the patient has from the police reports than the doctors and nurses in a hospital if they weren't evaluated by a forensic nurse. So I am a huge advocate for law enforcement officers to put as much information in those police reports as they can. It's very helpful. And then they should also go back and follow up within 24 to 48 hours with the victim. They may have newer complaints, newer injuries. You may be able to photograph other, injuries or signs and symptoms that have developed. Of course, they're going to do all the other things, that they would normally do, like interview the suspect, look at the suspect for injuries, maybe photograph those injuries as well, pull the 911 call to add to their police report or to turn over to the district attorney, audio record your interviews because there may be voice changes that you could hear in the victim on them, assist getting medical records if the victim did go to the hospital, and really know what your felony assault statutes are so that you could assist your district attorney in filing these charges, or you could actually recommend what charges you think should be filed in the case. As far as our advocacy protocol, or what advocates really should do, they should be instrumental in assuring patient safety, of course, but also help with that aftercare instructions, help to educate the victim as to how serious the strangulation is and could be. They could assist with symptom logging, when to seek medical attention, encourage counseling, and then all the other things we talked about, things like the safety planning, risk assessment, lethality assessment. Advocates also have a huge role in educating all the players in the civil, criminal, and juvenile courts as well, and then helping victims to know about potential long-term side effects and disability, or actually looking for it when patients come for follow-up. Once again, here we go with those risk assessment tools. Here's Jackie Campbell's danger assessment. And then here's the Maryland lethality assessment. It's a little simpler, 11 questions. Both of them are validated, widely used tools. The Maryland one was specifically designed for law enforcement officers to use at the scene. Both require training, though, to be able to be used properly. And just as a little note here so that you have it, it's in the handout. In Pennsylvania, law enforcement officers can use the Maryland lethality assessment that have been trained through PCCD, and you could contact Lois Fashnot at PCCD for that training if you need it, or your officers need it. Here's a brochure also available from the Institute. You could download from the website. It's printed in color, and it goes over some of the signs and symptoms and what to look for in the victim. And then on the back side of it, it provides a little bit of a log, or a way they can log some of their symptoms and things to look for, and then they could actually draw things on those little body parts to mark where they had a bruise or where they found something. And then from the prosecutor criminal justice response, I think it's important that prosecutors educate themselves on the seriousness of strangulation and understand some of the pathophysiology, have a good working knowledge of the felony assault statutes related to strangulation. They really should charge strangulation when appropriate in the sexual assault cases. They should really try to use expert medical witnesses, both for sexual assault case and strangulation cases. And it may be separate. You may have one person who's an expert in strangulation. You may have somebody else testify to the sexual assault piece of it. And I think, as a good prosecutor, you should help develop that expert witness in your community. Every community should have a handful, maybe one or two experts in strangulation, sexual violence that they could go to use at court. When we talk about what resources are available, here's that website, strangulationtraininginstitute.com. This is just a screenshot from them. All of the things I talked about are free downloads from them. A lot of them are underneath their library where their use of materials are listed. They have things like brochures, the protocols, signs and symptoms They have an assessment card. They have a paramedic card as well. There's other DVDs in that. So this is a great resource, and like I said, it's all free. The American College of Emergency Physicians has this e-book, which is an online reference for the evaluation and management of the sexually assaulted or sexually abused patient. You don't have to be a member to get it or to be able to download it. And there's actually a chapter in there on strangulation related to sexual violence. And then the International Association of Forensic Nurses have their non-fatal strangulation documentation toolkit, which is full of information. It's full of information and charting and how to document things. So that's available too. And I think, yeah, the website's right down there, forensicnurses.org. Okay? So just my final thoughts. I think it's great everybody came on board here. It looks like we've had about 100 participants throughout the webinar. You know, it's great to continue your education on strangulation. And as we learn more, we're happy to present more information to you because I think we're just scratching the surface with what we know about strangulation. If you're able to, try to read some of the medical literature. Some of it is not that difficult. Learn the simple anatomy and physiology because you may be that expert witness one day on the stand. Everybody should have some basic understanding of the medical complications, signs, and symptoms. Everybody should have an evidence-based practice, whether it's how you investigate the crime, how you prosecute the crime, or how you care for the victims. You should also know the limitations of your expert witness opinion, and that's in any expert witness work that you do. And as with everything, collaboration with our community partners is key. Okay? That's why it's so exciting to see a presentation like this, that we're having experts from the forensic world, we're having nurses, we're having advocates and counselors and law enforcement officers. And if I missed anybody, I apologize. But I think these are the best kind of trainings to have around strangulation. With that, I'm going to turn it back over to Babs and the PCAR folks so we can figure out how I can answer questions if people have them.
Thank you so much, Ralph. That was really terrific. Lots and lots of very good information there. Someone is asking, I think they might be asking if the Center County Women's Resource Center, the Rape Crisis Center, and Domestic Violence Center, if they have had strangulation training. That is something that we'd have to find out directly. I'm not sure what kind of training that they've had, but I will certainly inquire.
I know I've done some different trainings across the state, you know, to different locations, so that might be part of it. I do know that the Institute is trying to work with getting something here to the state. Now that we have our strangulation statute, one of the things we find is that people need education, and that's across all disciplines, medical, law enforcement, advocacy, etc. And we'll try to get as many trainings out to those locations as possible. So we were trying to work to get maybe some big, massive training in the state at some point. So I don't know where all that stands. I haven't checked in with the folks at the center or the Institute lately about it because we've been doing some other things. But keep your ears open for that. And if I hear more, I'll pass it along, and you know, Babs put out the word and that kind of stuff.
Yeah, that would be terrific. Thank you.
So
I do see a comment.
Yeah, I see a question from
I'm sorry.
David.
Yeah, go ahead and take David's question.
Sure. So I'm sure you could all see the question. Where are the jugular and carotid located? Is there a different method by which they are compressed? Thumbs in the front, fingers around the side. So that's a great question. So that goes back to the slide where I said what affects injury and potentially death. Yes, so as you know or may know, that the jugular veins are more on the outside part of the neck and are a little bit more superficial than the carotid arteries, which are more in the middle of the neck and a little bit deeper. So clearly, if just one or two fingers are being used or one or two fingers are directly located into those areas, you may get more of a jugular vein compression than a carotid artery compression or vice versa. The carotid restraint, which I mentioned, is actually designed to provide the maximal pressure on the carotid arteries. That's why the move is used to, you know, quickly block the carotid arteries, no blood flow to the brain leads to unconsciousness, and the person goes down. So yes, you can, selectively compromise one or the other, but probably in most cases it's a combination. You're probably getting jugular at some points, carotid at others, and especially if your hand is moving or the victim is moving, you're probably getting a combination of both. Okay, so let's see. I'll just take the next question. I see.
Yes, go ahead.
I see Vince's question about what would you say the most important information to know is. I think it's all important, but once again, you don't want to overwhelm somebody with information and scare them, especially during this time. So I think the most important information to know is that this could be serious. That, yeah, you might have survived this time and nothing might have happened to you badly, but it can get worse and it could happen again. And then after that, I agree with you. I think the future lethality of it, and to look for those other symptoms. So the symptoms of unconsciousness and incontinence, because those indicate that you're on the brink of possible brain death. What we know from some of the studies is that 15 to 30 seconds was needed to develop incontinence. So that strangulation was going on for 15 to 30 seconds with lack of oxygen, lack of blood flow to develop incontinence and that. So, that's a pretty significant strangulation. So I think little bits of information as you could give them to the victim are important, but I think just stressing to them how important it is to seek attention, medical attention, seek help, get law enforcement involved if you need to, because really, a lot of these cases, they're on the brink of a homicide.
Ralph, I certainly agree with that, and there might be some things that the victim might share with the advocate, things you might hear. Ralph mentioned, if they comment that they wet themselves, or if you can tell their voice sounds raspy, there's some things that you might want to just suggest could be some serious signs that they need to get that medical care, and encourage them to share that information with the medical provider or with law enforcement.
Absolutely.
And there was an earlier comment that Clinton County has received this training. So just there might be a neighboring county that has advocates that have some training that can be helpful with this issue as well. We do have a few more minutes. Are there any other questions?
Oh, that's
Ralph,
a great
do you
question.
see that question Val asked?
Yeah. So that's a great question. I actually don't know the answer to that one. I know there's tricks on certain phones like the iPhone and the Android phones that you could get emergency help without without people knowing it or without it being obvious. I do know that there's the ROAR, the company ROAR, R-O-A-R. They have the device that could be used to alert your contacts if you need help or that. I think it's called the Athena, A-T-H-E-N-A, but that's a little bit pricey. And it's an app with a device. I do know the One Love app that I mentioned. I don't know if it has the option to contact folks if you need it, but if you look at the app itself is just One Love, and it has a very nondescript appearance to it, so people may not even know what it is if you're just secretly trying to pull it up to get help or that. So I actually don't know that. That might be a better question for other folks on the call, or even to to app developers or the iPhone folks. And let's see, Paula followed up with, do we give that information to victims? Do you mean information about ways to get help or how to use these apps? The One Love app is actually designed that you could, okay, great. The One Love app is actually designed that you could do it yourself, or if, let's say, you have a friend who's in a DV relationship, you could use that as a way to help them assess the potential lethality of their relationship and that. I like it because in the emergency department, I have it on my phone. You know, if they don't want somebody called to come out and do a formal assessment, I could pull it up and ask them those same list of questions and then show them on the app, which to them looks unbiased because I'm not just saying it. Look, this says you're at very high risk for, you know, future death. This is a very seriously dangerous relationship. Can I call somebody to come help you? So I think that's why I like it. I paid the $2 to put it on my phone. I know the Institute has an app available that can help with documentation of things that can be linked to a Dropbox account. So for investigators and for even forensic nurses and advocates, you could actually upload things to it related to a specific case and that, so you could have it all in one location.
Well, thank you, everyone, very much. Thank you, Dr. Riviello. We certainly have appreciated all of this information. Great information today.
Oh,
and
thank
you, everyone. Yeah, well, right back at you. And have a good afternoon, everyone, and be in touch if you have more questions.
Great.
All right, thanks. Goodbye.